clearly, because once people finish excision biopsy and send it to us, we go in for a rewide excision because the prior excision will be without margin, and patient instead of losing 2.5 centimeter will be losing 4 centimeter of the tongue or the buccal mucosa. So it's a disaster for the patient. Treatment wise we will be completing, like the person who has referred and we would have completed, but then the morbidity will please them. So of course same thing, biopsy and imaging. See, whatever we are trying to tell today, like sir just informed about biopsy, imaging and all, please take it back, because what happens is, you being the primary physician for the patient who is referring, the patient many times, more than 50 to 70% of the time goes back to you and tells, I went to the oncologist, they are telling to do CT, MRI, PET, and then they are asking me to go for radiation, is it right, wrong? You know, so they'll come back to you as asking, is the treatment right or not? And when you don't know, at least, I'm not saying you have to do the treatment, if you don't know the treatment line itself, that this patient needs radiation, this patient needs chemotherapy, this patient needs only surgery, that's what we want to imply today, then you will not be in a position to say yes or no. You have to just close and okay, he must be feeling right. So please go, like whatever cases were like early case, late case, just take the final line that these patients need this as a workup and this as a treatment. So this is the scan, bone eroding pretty obvious over there, radiolucency is there. So
what is your plan of treatment?
So plan for all bone eroding operable patient will be multimodality. It will not be a single modality like the previous patient. It turned multimodality later, remember that. But primary plan was, it will be multimodality in which surgery will be first, followed by radiotherapy or chemoradiation as we go on.
As a radiation oncologist, why would you not want to give radiation first in this patient?
So when there is a bone involvement, radiation may not give the patient. So when there is not bone involvement, like single modality radiation is used only in early stage, that too after discussion, where patient is not willing for surgery. Often, definitive radiation for oral cavity cancer doesn't give a complete cure. There may be downstaging, there may be some response, but cure cannot be occurred. In this patient, definitely after radiation, they not give curative intent because bone is involved. When there is a bone involvement, it should be removed surgically, and to address a microscopic disease, we add radiation.
What happens if we give radiation to these patients and then operate? What happens to over and risk?
So, as a example, if this patient suffered radiation upfront, then doing surgery may be a big challenge because patient will have a lot of post-op morbidity. That will be very difficult wound healing, patient will suffer. And second thing, once you give radiation, the amount of healing is delayed. So like like pneumocystis, everything is there. And again, the primary treatment will get delayed because immediately post radiation you can't treat. So you have to wait for patient to come out of this radiation morbidity, which will take at least 1 month. This meantime, there will be a chance of progression where the patient can go inoperable. So when the patient is metastatic or very huge neural burden or not willing for treatment, unfit for treatment, where the intent is palliative, only that time primary radiation is addressed, or else wherever feasible, often surgery is the kind of care.
And this is what exactly we do in a tumor boards exhibition. We have a case, we know as a surgeon that I can operate and this is the best treatment. I still involve the radiation oncologist and the medical oncologist to get their opinions before the treatment is commenced. Because the patient needs to know that treatment doesn't end with surgery, the patient will require radiation, why radiation can't be given. All this, even though I explain, is nothing like hearing it from the horse's mouth. Now, we all agree that this patient requires surgery. What surgery will you do and what will be the sort of neck dissection you will do?
So why the local excision with that segment? Because it is a bone eroding tumor. Whenever the tumor has gone inside the bone, eaten away the bone, we don't do bone saving surgery, is called marginal mandibulectomy. In that case, we have to go for segment. This patient will end up with a central segment defect because it's a midline lesion. Now another problem with this midline lesion is that the patient will have drainage to bilateral neck. So he will kind of need a bilateral neck dissection also. So it is a little, you may feel it's a little morbid surgery, but it is needed for such a stage 4 central midline segment. And for advancement in surgery, if you all ask us as surgeons, me and sir, we have come into a level that we can give good bone for both. So we have good plastic surgery available now where we take bone from the leg, it's called fibula, and we place it in the central segment. So you can give a good shape to the patient. You can even rehab the patient with implants after 6 months or 1 year post the whole treatment is completed.
And the patients always ask, when we do a surgery for this sort of an anterior segment defect, why can't we put something else? Because we know all that these sort of free flap, osteocutaneous flaps, they require a lot of work and the cost also goes up. Can we not leave it like that? Can we not put a PFC? My neighbor had some surgery, they put a pectoralis major flap, why can't we do this? Because the cosmesis that you will get after an anterior segment loss is horrible. So it is important that we counsel these patients. When they see these sort of patients who have been operated before, they will understand that it makes a huge difference. So this is what we did. The post-op histopathology comes like this. 3 centimeter tumors, squamous cell carcinoma grade 2, tumor eroding the bone, resected mucosal and bony margins are free. 2 out of 28 nodes are positive with no perinodal spread. Now the patient is in the radiation oncologist room. Harish.
So as I told, this patient having E4 because of bone involvement and 2 node positive, definitely radiation. So my treatment plan will be reduce 60 grams to the tumor bed, followed by bilateral neck also. So usually when the patient is taken for radiation, this is a flow chart. We try to do a sort of immunization because radiation is not a one-day treatment. It goes for 6 weeks. So we need the patient to be comfort position every day and also the same position so that the delay is avoided. So patient will be subject to immunization, CT will be done, and whatever the basic we have, like diagnostic MRI or PET scan, we try to fuse the thing, we locate the tumor bed, we do contouring and we do plan to treat the thing, and once we get a better plan, we subject the patient to the treatment. So this is the information what I told. So we have something called as a thermoplastic mold. This is a pliable material which will flat. Once you put to the hot water, it becomes pliable. So it is placed on the patient face and customized to each and every patient size. So that when the patient comes for treatment, we ask the patient to lie down on the couch, we fix the mask. It makes sure that the patient doesn't move during treatment because it is very focused treatment. Even small movement will miss the target and lot of problem can encounter. So we make sure the patient doesn't move. And most of the oral patients where we have other than tongue area, we use something as a mouth pipe where we can separate the palate from the tongue so that aggressive radiation can be avoided to the palate. So this is what we use. We use eye sticks or use the cat where we can try to separate the palate from the tongue. The one that we use the board. This is the board water. This is called an AIO, all in one board, where we can use for all the cancer, like breast cancer, lung cancer, esophageal. We use this board where the patient can be lying in comfortable position. And we try to place the mask for all head and cancer to make the same position is reproduced every day. So this is my planning. So the era started from my practice like 2D. 2D means they will be skin marking only. The color one, the green color is the area for radiation. So first you can see that even though there is a problem in the tongue, the entire palate and parotid, even the spinal cord, everything is very radiation. Come to center picture where the treatment is little refined. The one, so if you can just show that red color, yes. The one which is showing red, no, that is my target area. So the trees here you can see, even though my target is treated, there is still of those outside there. So again there is a problem. So further refinement schemas, I am marking where you can see that the target is directly covered and the furrows are avoided. So further more refinement which is called as a VMAT technique in which the treatment time is made more faster. This all will take at least 8 to 10 minutes for treatment where we have because VMAT or Rapida, the CM treatment will exist in just 2 minutes. So patient with phobia, elderly patient, kids, where they can't learn for a long time, this treatment is mostly used. We now call something called therapy where the treatment is further focused to avoid the morbidity. So coming to brachytherapy as a gives, as I told, so brachytherapy is usually used in very small yearly oral cavity cancer where the patient is not willing for upfront surgery or sometimes we use as a boost. So as I told it is developed as a machine or Leucotron where the source what we use is iridium-192, SDR is high dose radiotherapy. So these source hydrogen isotopes are inside the thing and they are delivered with the type of treatment. There are various forms like intracavity, surface, interstitial retroperitoneal which are advocated for different type of cancers. So this is one of the tongue patient where I treated. So this patient had T1 lesion. So you can see that the picture C. So there was the lesion. You can see the small holes where the needles are placed. So these procedure needs anesthesia. It is not a open procedure. These patient will be proper anesthesia under GA, where the patient not will be wide open, and we have based on MRI. With the MRI, we track the disease and we try to implant. The approach will be submental. Via submental, we try to cover the tumor bed or with the defect margin. Once it is done, the patient is subject to CT scan, where we try to do contouring, and then the patient will be taken to the brachytherapy room, where the treatment is executed. Again, this is given twice a day for a period of 5 to 7 days. It is not 1 day procedure again. So the patient will be lying with the catheter in the wall for at least 1 week. So that time the patient will have problem in eating, patient will have problem in sleeping, because if they take to pull it out, it is a disaster. So patient go ahead and complaints more better. So we educate the patient before the procedure, properly explain with the videos, take the concern and then subject. So this one of the patient where again this patient was not going for radical surgery, he was always radical surgery, but he delayed. So this patient was treated with again brachytherapy. This post treatment we can see the complete response.
One subsite where radiation in early cancers is really useful is this sort of oral commission. No matter what you do, give good margins. Your competence that oral lips that is there can never be reconstructed with any amount of reflux or any reconstruction. So this is sort of the situations where we always involve the radiation oncologist, talk to the patients, maybe this is a right candidate for a brachytherapy. Now, so summarizing, this patient underwent surgery followed by adjuvant radiation. Now, concurrent chemotherapy, that is giving cisplatin, so these patients, I know that N1 will never give concurrent, but N2, N3 we do give concurrent. When do you choose to give concurrent cisplatin?
So, ideally, head and neck cancers, the role of chemotherapy is going to be very, very less. It's either surgery or radiation. As I have been just after the it won't be like the clinical practice. Okay. You see, most often the scenarios have been early cancer, but unfortunately, the Indian scenario is always an advanced cancer. So my part is always there